I saw a 28-year-old woman who came in for leg pain. This was her third time seeing me for leg pain. The first time I saw her, she had shortness of breath too. I sent her to the emergency department that first time. She ended up having leg pain from a blood clot in her legs that had gone to her lungs and caused a pulmonary embolism, a PE. She almost died. The second time I saw her, it was again for leg pain. Despite life-saving treatment, her leg still hurt and she wanted me to treat it. I noticed she was smoking, which increased her risk for another blood clot. Her lab results showed she wasn't taking the blood thinner prescribed, further increasing her risk. I dismissed her leg pain, saying, "It will get better with time. We need to focus on your tobacco use and you not taking your medication. You could get another blood clot." The second time I saw her, she was still smoking and still not taking her medication. She wanted me to prescribe something for her leg pain, which wasn't getting better, she said. I prescribed Tylenol and reminded her she could get a clot again and it could kill her this time if she didn't stop smoking and didn't start taking her medication. This was the third time now seeing her for leg pain. She said the Tylenol was not working. She wanted me to order her compression stockings. Her friend said it might relieve the pain. I saw she was still smoking. Her labs showed she still wasn't taking her medication. I asked her about the shortness of breath she had the first time I saw her. She said it had returned along with the chest pain. I told her, "You need to go to the emergency room. We can take care of your leg pain when you follow up. But now I'm concerned you might have another clot in your lungs." She said, "I'm not going to the emergency room because I know they'll admit me if I go to the emergency room. I don't want to spend Christmas in the hospital. I am not going to the emergency room." I work in a clinic in downtown Cleveland that's adjacent to an emergency department. The clinic was started in order for our hospital to make more money. The hospital was losing a lot of money because patients were presenting to the emergency department and leaving without being seen, LWVS, left without being seen. The hospital's solution was to filter out those patients who weren't having an emergency by triaging them in the waiting room and sending the non-acute patients to our clinic, staffed by primary care doctors. The patients who came to see us came in mostly for somatic complaints, back pain, headache, knee pain, stomach pain, genital pain. Their complaints were, by and large, the downstream effects of modifiable risk factors. 70% were overweight or obese, the majority had high blood pressure, prediabetes or diabetes, and risk factors, unprotected sex, unhealthy diet, sedentary lifestyles, and tobacco use. 40% smoke. Their bodies essentially were in revolt against the abuse they were piling on. These patients had never had health insurance and only had it now thanks to the Affordable Care Act. They previously had no alternative to receiving health care in the emergency room. They hadn't had a doctor care about them until they had some emergency that warranted an intervention. They in turn had come to think of health care as nothing more than a pit stop where problems would be fixed. When they came to see us, they wanted the care they'd received in the ED, which is relief from pain. This left us primary care doctors with an uncomfortable choice: address why they came in or ignore their somatic complaints and address the cause of why they came in. It was hard to conceive of doing both in the 15 minutes scheduled for each patient. Choose to do what the patient was asking, though, and risk uncomfortable interactions in the room and low patient satisfaction scores. Choose to do what promotes health, but have to quiet the voices in your head that told you you were doing nothing to promote their health. Either choice, someone was being ignored. If it wasn't the patient, it was yourself. Either way removed you from the moment, made you an automated checkout at the supermarket, following algorithms for treating acute illness or preaching benefits of a healthy lifestyle. I think many doctors feel this tension. I think it explains in part why physician burnout, especially among primary care doctors, is so high, and why surveys show that most doctors would not become doctors if they could do it all over again. The Affordable Care Act was a huge success in getting people health insurance, but having health insurance isn't enough if the healthcare system has neglected patients all their lives and thinks that handing out insurance cards can change this lifetime of neglect. If a population thinks of their health as something they need to be rescued from when they get into trouble, and doctors are trained for that rescuing, then providing health insurance is not enough to ensure better health. In the room with the 28-year-old, she began to cry. "I am so tired of this. I am so tired," she said. I stared at my computer. I thought, I am so tired of this. I am so tired of giving up even before the day begins. I looked up at her from my computer. We made eye contact. I saw her tears. I saw her tears were half from fear that I had caused, half from despair at her own condition. The one thing she wanted from our visit today, I had refused to give her: compression stockings. She might not even come back to see me, much less take her blood thinner. I went outside and got the pulse ox machine. I came back into the room and checked her oxygen saturation. 98%, not bad. I told her I really don't think you have a PE. I told her I would order her compression stockings. I really don't think you have a PE, but I don't want to risk it. And I'm really concerned about you not taking your medication, the fact that you're continuing to smoke. I know you're scared and hate that you have to go through this, and I really want to help you not have to live in fear like this. Would you please go to the emergency department? Can we please work together when you come back on your smoking and finding a way for you to take your medication? In that visit, something was clear to me. I had decided neither to ignore the reason she came in to see me, nor to ignore the reason I came into medicine. We both needed to change, and I needed to change first. I had found the middle ground. I had addressed why she came in, as well as the cause of the condition she was in. And because I was open to her, she became open to me. She ended up going to the emergency room that day, didn't have a blood clot, and over subsequent visits together has quit smoking and is consistently taking her blood thinner. She also tells me her pain is much less now that she has compression stockings. Now I get butterflies in my stomach just thinking about my next day in clinic. There is a lack of predictability and vulnerability when I open myself up to what the patient wants and seek as well to shift the conversation in our time together. I am open to failure. So much depends on their buy-in for success. I am exercising hope with each patient now, and I'm beating back my own burnout.